Hi, and welcome to Veterinary Journal Club. We are having our fourth vet books, which is chapter 3 in Small Animal Critical Care Medicine, second edition. And so, yeah, we're like, look at this, churning through the book, man. We're already at chapter 3.
Yeah, we went 2-month break, and now we've already had...
We're refreshed and ready for more.
And I even have one in the bank from a long time ago.
Oh, you still haven't put that one up? Which one? I don't remember what the topic was.
I think the one about sleep deprivation.
And then we forgot that that's what it was. That's a good, oh yeah, we did kind of talk about like, how do you manage sleep when you're working? Okay. We should probably put that out there for people.
Yeah.
But right now we're doing vet book chapter 3, episode 4. We really should have planned that differently. And so I was thinking about, what I want to do with this one, because this chapter 3 is CPR, cardiopulmonary resuscitation, doctors Fletcher and Bowler. And this is, let's see, how many? 1, 2, 3, 4, 5, 6, 5.5. No, mostly just 5 and a little bit. The rest of it is references. And that's one of the longest chapters in the book.
Yeah.
And this is like a teeny tiny scratching the surface of CPR. So it's a big topic and a lot of pieces to discuss. And so this is a really brief overview, really good. I mean, like these guys are really among the experts in veterinary CPR, in veterinary medicine, and two of the big drivers of the Recover Initiative. Do you know what that is?
No, is that when Jack does the punch to the chest in Lost and brings everybody back to life?
That's a precordial thump, and that's not really a thing.
He did it like 5 times.
Yeah,
in 7 seasons.
Oh really?
Well, there might be more seasons, but
like he like repeatedly did it successfully.
I'm pretty sure.
Yeah. So the precordial thump is like this theoretical thing that anecdotally has been reported to work in the case where I
saw it happen.
Yeah, on Lost, which is a very realistic documentary, actually. I think that was a documentary. Yeah. Real stuff. Anyway. So manual defibrillation, essentially. That's what that is.
Yeah. Yeah, he was a neurosurgeon.
Oh yeah, neurosurgeons are definitely the experts in CPR and doing a precordial thump. Anyway, anyway, the Recover guidelines have nothing to do with that.
Oh, okay.
But what it is, it's an initiative. Like, so in human medicine, there'll be like large groups of people that get together and they say, there's a topic that's really important. And there's a lot of research out there and it's all over the place. And we need a group of people, large groups of people, to comb through all that literature, to comb through all that research and pick it out and put it all together. And
like a meta-analysis?
Yeah, but like even bigger than that because it's over an entire topic. And so there'll be different domains. And so that was done, it's been done in human medicine, but they were like, we need to do it specific to veterinary medicine. And so the first Recover guidelines, oh gosh, when did those come out? A long time ago. They're actually breaking news going through the second round, actually. So we're trying to update. This is spearheaded by ACVEC, the American College of Veterinary Emergency and Critical Care Specialists. Yay. That's a fun acronym. And these guys are a big part of that still. So like this is a good chapter. This is written by the experts on this, but it's very condensed. So it is a good overview. But if you are really wanting to, know and understand more about CPR, going to the actual Recover guidelines would be great.
I guess a question that we haven't asked yet is what's the target audience for this book? Is it residents or is it students?
That's actually a good and interesting question. So
second year vet student?
So the pre-vet club first edition of the book, I think maybe they weren't sure who their audience was, or if they did, the publishers were like, no, that's not who your audience should be. So for the second book, the first book was, I really like the first edition. I think it's really good. And I used it during my residency. It was a little
more complicated.
Yeah. And so for my residency, I like that. I went into more depth in some of the topics, but for the average person who's working in a clinic, you're like, I don't need to read about the physiology. I have a patient who's like dying right now and I just need some help and I need it to be quick and easy and not dumbed down. That's not what they were attempting to do in this edition, but just to say, let's make this a a useful reference, not for preparing for boards, but for practicing emergency and critical care medicine.
Yeah.
And so this edition specifically, the goal was to target practicing veterinarians in emergency critical care. Like that's who it's for. So it's meant to be a reference for, hey, I'm working, maybe I'm a recent grad and I'm doing an internship, or I'm picking up some relief shifts on ER, and this isn't necessarily like my, this is this reference.
So they would have liked you to
you
have graduated vet school if you're reading this book.
They say again?
They would have liked you to have had graduated vet school if you're reading this book.
Not necessarily. I mean, I think it.
Well,
you know, if you're a
you-
first year vet student, you're going to struggle with a lot of this stuff.
Yeah.
But if you're like in your third, fourth year, you're in clinics and things like this, I think this could be a really good reference for a lot of stuff too. Some of it's going to be a little more advanced, but that's true of any book, right?
Yeah.
But no, I think if you are approaching graduation, getting ready to, I think this from there beyond, it can be useful.
Yeah. So if you had like your ECC course, do they have a book that they go by, or you just tell
This
them?
would be a good reference for that.
Yeah.
Yeah. This would be a good reference.
All
So
right. That was an aside. I was like, oh, I don't know what this book who is meant for.
yeah. Sorry, just responding to a work.
Always working.
Yeah.
Probably
the
works
life.
too much.
It's true.
All right.
Okay.
CPR.
So what do you know about CPR?
Is on Lost, Jack just punches the guy and it works.
That's the extent of your knowledge of CPR?
Oh, and in Sandlot, it's how you get to kiss girls without their permission, which
my
is
gosh.
not right.
So how you can have non-consensual. Yeah, that's pretty messed up actually now that I think about it.
There's a couple there. There's one where like someone was drowning. Another one?
He pretends to drown.
Okay.
Yeah,
maybe it
the
was
little
that movie I'm
kid.
thinking of.
Yeah. The glasses. What was his name?
Oh, and there
Weeks?
was the other, in Old School they have it.
like
Wilfer
your-
actually is getting CPR and he needs it. And then he starts making out with the 3-name guy. What's his name? He's in the
3-name
American
guy?
Pie movies.
The 3-named guy?
He's like Scott Van Prep or something. What's his name?
I don't know.
Sean. His first name is Sean.
Oh, Sean William Scott.
Sean William Scott.
Something like that.
Yeah.
Sean Scott.
Yeah,
and
he's
William
giving him
are his names.
CPR and then Will Ferrell kisses him and then he kicks him back into the pool.
Oh.
That's about what I
Your
know about CPR.
references. I love that these are your references. They're not even like medical dramas. They're just like random things like comedies
In
and
Lost, he's a neurosurgeon. This is absolutely a medical reference.
it's not, but like ER, Scrubs, Grey's Anatomy, like there's
I didn't really watch
House.
those shows.
Yeah, no, I know that's funny.
Well, and Sean, whatever.
Sean William Scott. I
Sean
think
William
that's what it
Scott, he has a petting zoo, so he's probably a vet.
is. He has a petting zoo.
Yeah, he
I'm
runs the
pretty
petting
sure
zoo.
never in the history of petting zoos. Well, anyway.
I'm pretty sure almost every vet
So you
has
know-
a petting zoo,
so you
whether
know-
they use it publicly or not.
So you know a lot about CPR.
Yeah.
Is what we're getting at here. So so you know then that we often break it down into basic life support and advanced life support.
Yes.
Yeah. So basic life support is what you would probably generally think about when you think of CPR, with the exception of on Lost, where the only CPR they apparently ever do is a precordial thump. But in basic life support, we're talking about chest compression. So that's the part you think about, beating on the chest, but more than once if you're going to do it properly. Repeatedly, rhythmically, there's features to it that make it
70s
very
music.
important. Yes, exactly.
Yeah, I edited
Do you
that
remember
video.
that? Oh, that's right. Yeah, that's right. Because
I've edited a couple of your lectures on
That's
CPR. I
right.
know a little bit more.
That's right.
I'm
yeah,
lying.
you're playing dumb. Yeah, you've done a lot of you helped me take a ton of videos. We did a bunch of like instructional like videos of me doing chest compressions. Yeah, you know all this stuff, you big
Yeah.
liar. All right, he's playing dumb for your benefit.
Yeah.
So basic life support is chest compressions, breathing, like intubating them if possible and breathing for them. And like, that's kind of the majority of it. So airway and breathing, ventilation, all that kind of stuff. The monitoring during CPR, this is like probably, I think, the most important thing. Maybe that's hard to say, the most important thing. A very important part of CPR is understanding how you monitor your patient during CPR. And there's two main things you need to think about.
Is one of them in Tidal CO2?
Yes. Gosh, you're so
What?
smart. You're so good at this.
I just guessed.
That is the most important thing. If you only have one monitoring tool for CPR, it should be Tidal CO2.
I have no idea what it is, but I know that's a word.
Yeah,
I didn't even know
capnography.
if I said it right.
You did, and you totally did. Tidal CO2 or capnography. So measuring the amount of carbon dioxide that the patient is exhaling essentially. The interesting thing, normally in an awake, alive, not necessarily in an alive patient, your CO2 tells you about your ventilation or how many breaths you're taking, basically gas exchange. How much CO2 are you exhaling? The problem is when you're dead, it doesn't matter how many breaths you take or are being taken on your behalf through positive pressure mechanical ventilation, because in the body, do you know where CO2 comes from?
CO2 comes from your lungs?
Nope. That's a lot of times what people think. Your lungs are actually just what allow it to leave the body. But you breathe in oxygen, and that oxygen gets delivered to your cells, and then your cells taking the oxygen go through cellular respiration, and a byproduct of that is CO2. And so it's happening in your tissues. But
is there some fancy name for that everybody should know that's a vet student?
Cellular respiration?
Oh, I was just thinking like a Krebs cycle or a blah, blah, blah phosphate.
Yeah, there's all those things. All that. Yes, you should know that. Just call it cellular respiration. That's fine. Bring in O2, get rid of CO2 to make some ATPs and things like that. But that's happening at the tissues. So all the CO2 is just sitting there at the tissues. And how does it get to your lungs?
Your blood?
Yeah, good. Through your blood flow. So if you're dead, what's your blood flow?
Not very good.
Yeah, there is no blood flow in a dead patient by definition. Yeah. There's no blood flow. And so all that CO2, so if your heart stops beating, you are very soon after that, you'd be considered dead, but your individual cells haven't died yet. Like they're still going through their cellular processes. So there's still any oxygen they have, they're going to, create CO2 as a byproduct of that. They might even be undergoing some anaerobic metabolism, so on. But all that CO2 is building up and it's sitting out at the tissues, just sitting there. Can't go anywhere because there's no blood to bring it back to the lungs. The gas exchange that happens at the lungs happens passively, just down a concentration gradient. So there's not a lot of CO2 in the air. There's very, very little CO2 in the air. Thank you, trees. And so there's about 21% oxygen, but less than 1% CO2. And so if there's comparatively a lot of CO2 in your blood that was, created or exchanged in your tissues, then it's concentration gradient, lot on this side, none on that side. And so all the CO2 leaves. So in a dead patient, if you can use some bellows to pump air through the lungs, the gas exchange will occur. The problem in a dead patient is that the CO2 isn't at the lungs because that requires blood flow to get it there. So all of that is meant to explain the point is monitoring CO2, the end-tidal CO2 during CPR is telling you about perfusion because the CO2 is there. It's just out of the tissues. If I can get it back to the lungs, it will come out of the body. I will see it. So when I see a low end-tidal CO2 in a dead patient, that's what I expect. It's zero if we start doing chest compressions, that number should climb the better our compressions are, the more blood flow we are generating.
The blood.
Yeah. So we're trying to, it's never going to be as good as a heart. The heart is going to be better than me doing chest compressions, but I can kind of get a gauge for how good am I doing? Do I need to do better? Do I need to try harder? Do I need somebody else to step in for me? Or do we need to, convert to open chest CPR or something else? So that is an important monitoring tool to kind of tell us how are we doing. The other thing it's really useful for is telling us if our patient likely has come back, if the heart started beating again, because as I said before, a really crappy living heart is better than the best person doing chest compressions.
Right. Cause you're pumping a broken pump.
Yeah. It's not very good. So if you have you're monitoring the end-tidal CO2 and
it'd be you cranking your car engine by hand.
Yeah, it'd be really inefficient. It'd be much better if you got the engine to start. Yeah. So if you get the engine or the heart to restart, you're going to see that CO2 suddenly jump. Because you're there's so much CO2 that was at the tissues that's now coming back. Even if it's not a lot, it's a lot more than what you were doing before. And so the cool thing is end-tidal CO2 can be measured continuously, and it doesn't, we don't get interference from me doing the chest compressions. And that'll be important when we talk about ECG. So I can use that to be the CO2 suddenly went from 12 to 36. Guess what? That's probably because my patient came back. I didn't suddenly become really strong. That it didn't happen where I was I'm so tired. I got my second wind and now suddenly I'm doing amazing. It doesn't happen that way. So a sudden change, a sudden increase in end-tidal CO2 indicates ROSC, or return of spontaneous circulation. What are you laughing about?
You're talking about like you're going to get suddenly strong and good at chest compressions. There's a video of, I think it's like a CPR robot that they're in testing. Have you seen it?
No.
So it's
but I like it.
It's just like this brace that goes around, and it's got a kind of like a plunger looking thing that goes up and down, and it's they turn it on and just like crushes the skeleton. It's a model, but
right? But like the first time, it's
just like boom, like pounding this model and destroying it. And I'm like, oh, that was a little too tough.
Oh my gosh, we have to watch this later. That sounds good. You should. Maybe we'll put a link.
I'll see if I can find a link to it.
Yeah.
I'll put it on the podcast.
So the other thing you monitor is ECG, or the electrocardiogram. But really, the only thing this is good for is deciding if you have a shockable rhythm or not. That's, I don't know what they may say other things about that, but basically it's important for deciding whether or not you need to defibrillate. If you don't have a defibrillator, then this probably isn't really that important. And it's not useful during CPR. You actually have to stop CPR in order to even assess the ECG, because if you're doing chest compressions, which is the mainstay of CPR, then it's going to interfere with your ECG, because the electrical, it's going to be chaos. So you won't be able to interpret the ECG unless you pause CPR for a moment. So you have to kind of weigh out the pros and cons of that. But it is important, because if you have a shockable rhythm, the best treatment you can offer them is defibrillation. So if you have a defibrillator, then you should totally check the ECG once in a while.
How common is it for like a normal practice to have a defibrillator?
A lot of them won't have it.
Yeah.
And so what I'm telling you is, if you don't have a defibrillator, it's okay. But maybe prioritizing the ECG isn't that high. Like, don't check the ECG frequently, because
there's no
it's
reason.
not going to change what you do.
Right.
You just keep doing your CPR and hope for the best.
It's a waste of time.
Yeah. Well, because every time you stop chest compressions, cardiac output falls, which is not what you want, because, it goes to zero, because the dead patient has zero cardiac output. There are some chemical defibrillator, or, basically you could give lidocaine or they don't work as well. Defibrillator is going to be the way to go. If you have a defibrillator, then you need to find out if you should use it. But that's more advanced life support stuff. So
what's like the amperage of a defibrillator?
Of a defibrillator,
like the amperage voltage type deal.
So
the
amperage.
Right
well,
there?
I have the joules. So
joules, that works. Yeah,
okay, I was going to say, I don't know if I
just
can
didn't think they
convert
would list that.
I don't know if I can convert that to amperage. Okay, yeah. So
do you want to know? I think it's what is it? It's I squared V. No, IV. It's just power. Power is current times voltage.
Yes.
And so power is.
You've lost me.
Power is energy over time, so that'd be.
Yeah, I remember that one.
Yeah. So that would be.
I don't know.
Yeah.
To convert this to amperage, we can do that later.
But joules, I'll be able to understand that.
Okay, good. So there are monophasic and biphasic defibrillators. So one direction or there and back. And biphasic is better, because you can use lower energy and to get essentially a similar effect. So it's a little bit safer, better outcomes with biphasic. So most, I don't even know if you can get a monophasic, like a new monophasic defibrillator. Probably it would be a challenging thing to try to find, because they're all just going to be biphasic now. So you use about half the energy if you're going to do biphasic. So this is not the kind of thing you should ever memorize. I mean, definitely you shouldn't, but even if you're doing it,
just for fun.
But there are charts. So 2 to 4 joules per kilo is the reference.
Cool.
But
I was wondering, is it a lot of energy? Or 2 joules is a lot of energy.
So 50 joules would be like a small patient, 50 joules.
Yeah.
100 joules for like a medium-sized patient, and 150 joules for a big patient. Like, that's a good rule of thumb. Because a lot of the defibrillators, you can't choose like 17 joules. It's like 50, 100, it might be like 50, 70, 100, 120, but they're not going to be that precise. You can't enter 37.4 joules, and that's what you want to deliver.
How many gigawatts is it?
30. You obviously, sometimes if you do open chest CPR, you do internal defibrillation, and then it's like a tenth of that.
Yeah.
So you have the little paddles, and you put them right over the heart, and you. Bzz.
Yeah, because you don't have any resistance.
Right. You don't have to go through the whole chest.
Do you have to worry about like burns and stuff like that? Yeah.
Good. That's what in like the TV shows and stuff, when they get the defibrillator paddles out, and they put like goo on it and then they rub it together. People think rubbing it together is like charging it. That's not it. It's not like friction. It's not a friction thing.
It's plugged into
but
the
you're
wall
putting
as it
the gel, and exactly, you're putting gel on it because the gel is supposed to improve the contact and reduce the risk of like starting a fire with this electric. But so like the fur, you're not supposed to don't use alcohol, because a lot of times when people hook up ECGs to animals, they use alcohol to get better contact. That is flammable. You should avoid it. Please don't set your patients on fire during CPR.
Well,
don't set your patients on fire ever. Like not just during CPR, but
look
never.
Like they're on fire.
Well, you could start a fire because then they also have like an oxygen source down. You add that to oxygen, a spark. No. It's a dangerous situation. You could absolutely you could create a bomb. You could turn your patient into a bomb, because then the fire goes like on the inside of their endotracheal tube, and then whoosh, and then you burn them from the inside out. You're done at that point.
This is terrible. Why would you do this?
You wouldn't do. I'm telling you not to do. These are things to not do. Don't set your patient on fire inside out, or outside in for that matter. Don't set them on fire, please. Okay, but open chest CPR is pretty fun.
Yeah.
You know what that is?
I assume that you open their chest.
Yeah.
And then you
crack the. People like to say crack the chest. There's no cracking involved. Yeah. There's cutting.
Ew.
Yes. But there's not as much bleeding because they're dead. So they don't bleed as much.
So do you just like grab the heart in a certain way and like
kinda
squeeze? Do you have a stress ball that you can practice your heart squeezes? There is.
Yeah. I mean, there isn't a specific one for this.
It seems like there should be.
You could use a stress ball.
Because I would think you would have to squeeze it like a certain way in order to pump it correctly.
So you do want to squeeze it from apex to base. So like the pointy end of the heart towards the base, because that's the direction you want to squeeze it.
Also, I don't know if dog and cat hearts are like people hearts. Are there 4 chambers and all that?
Mm-hmm.
Okay.
Yeah, they're pretty similar actually. I mean, they're slightly different shapes and stuff, but they're pretty similar. So depending on how big the patient is, you either get one hand or two hand.
I was going to ask, do you want to have small hands or big hands for this?
Yes. It depends on the size of so we get such different size patients. Now, usually we're doing open chest CPR in larger patients because you can't get your hand in a really tiny patient. Yeah. Doesn't mean you don't open the chest. The last actually successful sort of did CPR on a dog that was referred over, had a history of some pleural effusion. It like arrested right when it got there. So we start doing CPR. The owner's like, yes, let's do CPR. And it was like, we need to do open chest CPR. It was like a little dog, like a Shih Tzu or something like that. And they okayed doing open chest CPR. So I cut the chest open and then flipped it over so all the fluid would flow just by gravity out. And then we did CPR there, got it back.
I saw that video. I didn't like that.
You saw that video?
Not of the Shih Tzu, but of another dog when you like poured all the goo out of its nose and it came back to life.
That's so gross. Yeah, that is a good video. No, this one was directly through the chest. So I cut a hole in the dog's chest.
Ew.
Then all the fluid came out. Then we brought it back and it came back and it was actually fairly stable. And then we euthanized it.
Oh.
They didn't really have the money for all the things it was going to take. We just didn't have time to have the in-depth conversation initially. We just had to make that decision. So yeah, we had a successful one, but we didn't do internal cardiac massage. That was just like cut a hole in the chest to drain everything out, because if you try to do like a thoracocentesis, you can't do that while doing CPR. So that was kind of a messy thing, but it worked. It went well. What was the last open chest I did before that? But yeah, so you basically just cut a hole in between a couple of the ribs, and then they have finished shadows. It's a special instrument where you put that in between, and they're called rib spreaders.
It sounds like a Mortal Kombat finish shadow.
Yeah,
rib spreader.
Yeah, what was it called? What is it? Perfect, flawless victory. That's what I was trying to think of. Yeah. So there's the finished shadow chop. Flawless. You got a sound effect for this?
No, I'm just getting sound effects ready for later.
Okay.
I just remembered because I should get those sound effects. It's like, I do have some sound effects for later.
Yeah. So, I mean, here's the other thing that people should know about open chest CPR. If you are not in a facility where you can do open chest CPR or have somebody that could follow that up with like to clean it, like if you get them back, now somebody has to
close
fix that.
The chest.
Yeah, you need to know what you're doing. And if you're not capable of doing it, that's okay. Just don't offer it. It's not the end of the world.
Yeah. You need to have somebody
just say, hey, this isn't a thing we can do.
Do opposite.
Yeah. Now that I've made a mess of this, I need you to fix it. But I saved the patient's life. I need you to not screw it up from here. Thank you. Surgeons love that. So anyway, like don't feel bad if you are in a situation doing CPR and you don't have all the things available to you. Like it's okay. Just be like, we did the best we could, or tell the clients like we're not able to offer these things because we just don't have the capabilities of them here. Like we're not going to be able to do open chest CPR. That's okay.
Well, you haven't talked about the success rate of CPR yet.
That was intentional.
Yeah.
It's not good. So it turns out...
So you shouldn't feel bad because it's...
Yeah, that's a good point. So it turns out that dying is bad for you.
Yeah.
Yeah. It carries a poor prognosis. Death is and so I kind of, it's kind of joking about this, but it's true that no matter what disease your pet has or the patient has, it's the most severe form it could be by definition. It can't get worse than that. They died. So this is like the least stressful thing I do. Everything leading up to the dying, like that's where you should be like, we got to get stuff done. We got to try to keep it from dying. Once it's died, it's like, okay, well, that was a bummer. Let's do what we can to bring it back. Sure. But like the worst that can happen is that you bring it back and then it dies again. I don't know. I mean, like it's dead. The only way you can kill it again is if you first bring it back.
Yeah.
So don't stress about like your energy should really be spent on trying to prevent the animal from death. The most successful CPR is the one you didn't have to perform. Like that's the most, the actual CPR has a pretty crummy, do they say that in this chapter? Do they talk about success rates?
I didn't read the chapter.
So the other thing to know,
I just looked for fun words from it.
The other thing to know about
I even forgot
CPR,
the author's name.
When you're, shame on you.
What is it?
Dan Fletcher and Manuel
Fletcher.
Bowler. Yeah. So the other thing to know though about success rates is you have to know what you're talking about. You have to know what the, how the success was defined, because there's a difference between ROSC or return of spontaneous circulation. And in a lot of studies that is successful because it's in a laboratory study and that's like the end point. But clients don't care if you got ROSC and then their pet died again and it never went home with them. Like the only thing they care about is, did my pet come home with me alive?
Do they count ones like, oh, we got it, like your Shih Tzu earlier, we got it returned, or something that's like, oh, it had terrible cancer and it died and we got it back from CPR, and then an hour later it died again from
and that's
the same thing that it would die
perfect
from
question
before.
That you have to ask. So if they are not successfully discharged from the hospital, I don't count that in a success.
Yeah.
Again, now it depends on what you're talking about. If you just want to know what's the rate of return of spontaneous circulation, those numbers are going to be higher. But that doesn't mean squat to the pet owner who's like, great, you brought it back and then it died again. That doesn't do me any good. I never got to see my beloved pet again.
Yeah.
So you do have to be careful when you're looking at those numbers to know. Okay, so this is the first sentence in this chapter. Cardiopulmonary arrest in cats and dogs is a highly lethal condition because death is deadly, with rates of survival to discharge of only 6 to 7%. Cool. Now, if you look at, what does this one say? Guidelines has led to substantial improvements after in-hospital cardiopulmonary arrest from 13.7% in 2000 to 22.3% in 2009. That's in people. But if you look at like individual studies that talk about ROSC, those might be significantly higher than that.
Yeah.
But that's not good enough.
So 6% with like CPR cases was the success rate?
Yeah, it looks like.
That was better than I thought it would be.
Yeah.
Honestly.
It's not like a it's a mini miracle, but it's 6 to 7% is not terrible. It goes higher if it is an anesthetic related death. So if they died, dog was going to get spayed and she died under anesthesia, it goes up to about 25%.
That makes sense because they didn't have a disease or anything.
Exactly. Their lethal disease was anesthesia.
Yeah.
And you can reverse that.
Yeah.
So the numbers go higher in those situations. So a lot of it is just patient selection too, right? Like if you have a patient that has 3 different terminal diseases, that maybe isn't a great one to recommend CPR in. Like, what are you gonna, if you have treatments that you still could do them now before they've died. Don't wait until after, like, oh, well, we were going to do this life-saving thing, but he hadn't died yet. So we thought we'd wait for him to die, bring him back and then try it. Like, no, like you've probably exhausted all of your options in some of these cases. So there's a difference for me than the patient that's like sitting in the ICU and we're doing everything we can to keep it from dying. And despite our best efforts, it dies, versus the animal that came in on emergency, or we've only had it for a short while. We haven't had a chance to like do the things that we think would save it, and then it dies. Like, all right, let's keep trying because we still have some things left to do, if that makes sense. Yeah. So anyway, but don't feel bad if it doesn't go well.
The equivalent for like a animal DNR, is that a
We call it a DNR.
It's a DNR.
Yeah. Yeah. It just means do not resuscitate.
Yeah. And
Yeah. So it's an
like, is that
advanced
something
directive.
that's a discussion that's had immediately upon?
It should be.
Yeah.
Oh, this should be a whole second podcast.
Yeah.
Have we
Maybe
done
it's
this?
a chapter later.
I don't think it is.
I think we've talked about it
I think we have two.
briefly.
Maybe we should have an in-depth one. We'll do chapter 3, part B.
Yeah.
We'll do that
You
next time.
should talk to some vet student about it.
Okay, I'll do that. But yeah, this would take me the entire length of our current podcast and then some to go through this because it's a super important topic though. I'll see if I can recruit a vet student to talk to me about it.
Yeah. All right. What else you got for the CPR chapter?
That's it. That's all I got. I'm done.
That's it. So you're ready for the back. I went a little further than I thought. The backwards game that we stole from 92.3, whatever they're. Whatever.
The morning thing.
The morning thing, yeah.
Is the name of the
show. If you live
show.
in Blacksburg or
In
Roanoke,
Virginia.
you may know.
Yeah, in the New River Valley area.
All right. So I chose the words really well, apparently, because you've said them all.
Cool, but not backwards.
But
I
not
haven't said
backwards.
any of them backwards.
So what this game is I'm going to play a sound clip backwards. And it's so the first one is CPR. I'm going to play CPR backwards. And Bobby has to say it backwards. And then we're going to do that backwards and see how close she was to saying CPR. This is our first time doing this, so
it's probably going to be terrible.
Forgive us if it's bad. All right, you ready for the first word? It's CPR.
CPR.
Raíz.
What?
That's CPR backwards.
Okay.
You want to hear it again?
Yes.
Raíz.
One more time?
Raíz.
Okay.
All right.
Rabies. Okay.
All right.
Are we going to listen to that?
Yeah, give that a shot.
CPR.
Yeah, that was pretty good.
That was so good.
Yeah. Hold the phone a little closer to your face when you do it.
When
next
I
time.
record it?
Yeah.
Okay.
Yeah, we're using my phone.
But I think you could probably hear that.
Yeah, I can
Do I
hear
need to play it again?
Yeah, you can play it again.
CPR.
CPR.
Sounded drunk. CPR.
All right.
That's so good.
The next one is chest compressions.
Oh, geez.
They get harder as they go.
I would say so.
Yeah,
CPR was harder. I thought it was just going to be not that
You thought
hard.
I was going to RPC?
Kind of.
All right, you ready? This is chest compression.
Chest compressions. Okay.
Did you get it?
You're going to have to play that a couple more times.
You want more?
Yeah, one more. Schnup, snarpik, schnesht.
You can't laugh while you're doing it.
Okay, this is
right.
going to be so bad.
All right, let's do it. It sounded like it was backwards again.
Do I need to try it again? Let me try again.
Yeah, okay.
Okay.
All right, here's the sound. Listen.
Schnipp, schmark is freshed.
All right. Nah, this one is a fail.
Okay,
Oh,
I
wait.
fail. All right, fine. Womp, womp, womp.
Let's go.
Yeah, okay. All right, fine.
All right,
What's
the
the
last
next one?
one
Okay.
is, I think,
Is
hard
even
also.
harder.
It's even harder.
Okay.
Electrical defibrillation.
Defibrillation. Okay.
Defibrillation. I have trouble with the R, I guess.
Yeah, it's a weird word.
You ready?
I guess. Again. One more. Miss Schiller more electric.
I don't think that's going to do it.
No, it's not at all. Fibrillation.
I heard
You could
fibrillation.
the fibrillation.
All right.
Okay.
Yeah.
It was too
Let's
many
do it again,
words.
and then it's 2 words.
I know it's too many. Defibrillation is that's like a million syllables.
Yeah.
Okay.
Well, that's what you get for being
Can
a
we
vet.
just do Can we just do defibrillation? The electrical part. Come on.
You can try defibrillation. Are you ready? Just don't do the last half.
Okay. Yeah.
You ready?
Yeah. Okay. Defibrillation. Yeah. That was way better. It was
Yeah.
just too many syllables to keep track of.
Yeah.
The 2 words. All right. So I get half credit for that one.
No, you did pretty good. You got the CPR reel. The other two, I was like,
The CPR was pretty good. What was I don't remember what the second one was now.
Chest compressions.
Chest compressions.
I thought that would have been easier, but no.
No, that was terrible.
No.
You should try it. Here, you try it
No,
backwards.
we're good.
Okay. That's pretty fun though.
That was the backwards game.
Backwards.
I'll try to do better next time.
Yeah.
I only had a few minutes before.
That was pretty good. It's fun. It got me laughing. Hopefully you guys enjoyed it. We'll keep working on the games, but that's one that we enjoy listening on the radio. Like I giggle about that one quite a
they're
lot.
always able to do it. They
They're
must
really
scream
good.
the words.
Yeah, they probably practice and stuff. But that's okay. It was still fun. And so read this chapter on CPR. And then refer to the Recover guidelines, and then be on pins and needles for Recover 2.0 for the revamping and the updating of the Recover guidelines as well. So this is a nice overview. It's a good place to start. Chapter 3.
Don't forget what the next chapter is before we close the book.
And then get ready for Chapter 4, which is appropriately post cardiac arrest care. So in that 6 to 7% of the time when you bring them back, what are you going to do about them now? This is when the really hard part begins. So be ready. All right, we'll see you next time, or hear you, or I don't know,
Bye.
Bye.